Because many OPOs operate in a low-quality data environment and without appropriate oversight, almost 5,000 patients did not get adequate organ procurement care, and nearly 12,000 other patients did not receive life-saving transplants.
One thing that is clear to me, now that I have watched these hearings multiple times, is that OPOs are not all failures. Some of them are doing a great job speaking to families on the worst day of their lives and procuring organs that will save the lives of others, and doing all they can to match those organs they collect with patients who can use them on the wait list. And some of the people who run those well-run OPOs are going to be some of the people you're hearing testifying today. But what I want to make crystal clear here is that OPOs, in general, are not the enemy. But some of them are failing, and failing badly.
In this environment, who's looking out for the patient? Who's being held accountable for poor patient care? No OPO has ever actually been decertified, regardless of its performance or its safety record.
I am so damn tired of being lied to. I don't think I can deny it anymore. If you think it flies, but I'm not gonna buy it anymore.
Hello, my friend, and thank you for listening to the 281st episode of Congressional Dish. I'm your host, Jennifer Briney. If this is your first time checking out this show, first of all, thanks for listening to it. And if you enjoy it, I would really appreciate it if you'd share it, because this show is about what Congress does after we elect them, which is very different from a lot of the other shows. In fact, almost all of the other shows that exist in the United States, which cover politics, which cover the he said, the she said, who's raising the most money, who do we think is going to win in the next election. I mean, so much of political news is actually predicting of the future. It's infuriating. And so what I do is I watch what Congress actually does. I tell you about the past, about the things they have done with your money and in your name after we elect them to office. And this episode is about some hearings that I watched, and honestly, the content of these hearings kind of blew my mind. Because this episode is going to be about organ transplants and our national system for coordinating them. And to be honest with you, I never really thought too hard about organ transplants, mainly because I never needed one, nor do I know anyone who's ever needed one. Most of my knowledge of the organ transplant system in the United States, and I'm not proud to admit this, but it is true, most of my knowledge comes from episodes of Grey's Anatomy. And in those episodes, the script is always the same. A person needs an organ transplanted, and if they don't get one soon, they're going to die. Then the call comes from UNOS, the United Network of Organ Sharing, and everyone reacts as if angels from heaven are on the phone. Then, of course, the doctors rush to get on a plane to collect that organ, and they usually make it back just in time to save the patient, unless, of course, there's a main character that Shonda Rhimes wants to kill off in a horrific plane or automobile crash. I'm still mad at her for some of those crashes. But in all of those storylines, and in like the 2 decades that show's been on the air, there have been a lot of them. In all of those storylines related to organ transplants, UNOS, the United Network of Organ Sharing, is the solution. They are the savior. They're never the problem. And so I've never given that organization a second thought. That is until, however, I happened upon some hearings about UNOS which have taken place over the course of the last 3 years in Congress. And in those hearings, which you're going to hear testimony from today, I've learned that our national system for coordinating organ transplants is a mess, a dangerous mess, and it's costing thousands of Americans their lives every single year. And so in this episode, we're going to examine the testimony provided to both the House and the Senate over the course of the last 3 years about what is wrong with the current system for coordinating organ transplants in the United States. And then I'm going to tell you about the bill that aims to fix those problems. The testimony you're going to hear today took place in the House Oversight Committee in 2021 and the Senate Finance Committee in 2022 and 2023. This is one of those episodes during which I'm going to mix the testimony in a way that best tells you the story. And I just want you to know up front that we're going to jump all over the place between these 3 hearings. So much so that I'm not going to bother introducing which hearing each piece of testimony came from, mainly because it doesn't really matter as nothing significant has changed during the last 3 years. But I do understand that you may want to know when the testimony was given, and you may want to hear parts of these conversations in full. And so in this episode's show notes, I've provided links to all 3 of the hearings. And I've provided timestamps and transcripts to every sound clip that I used. And actually, I provided timestamps and transcripts for a lot of clips that didn't make it into the show. So there's actually more there than what you're going to hear. But please use these resources to easily find and watch any of this testimony, and of course, to check my edits to see if you think I'm being fair. Also in the show notes are links to the Senate Finance Committee's investigation documents that provide many more details than were discussed in the hearings. And so if you really want to jump down this rabbit hole, that staff report is worth your time. It's not long, but it's definitely fascinating. And I'm giving you all of these sources because trust is earned. And this is how I've earned the trust of thousands of people who have been listening to and financially supporting this show for many years. I don't expect you to trust me. You really don't know me. I am a stranger on the internet. And so I don't expect you to just trust me or my edits. I want it to be easy for you to check my work and judge for yourself if you think I'm fair in my presentation and analysis of all these really important issues that I cover. And because trust is so central to our relationship, I don't allow anyone, as in I don't allow any company or politician running for office, to pay me to say anything to you. In other words, I don't accept money to run advertisements on this show, and I am committed to you that I never will. I want you to be able to trust that everything I say to you is because I believe it. I don't want you to ever have to question if you're being told something by me because you think I might be getting paid. I'm not getting paid. At least not by them. Because instead of making my living by selling your time and my reputation, I make money by providing you these episodes up front and the show notes, which back up everything I say. And then you get to decide how much this production is worth, either to you or to the world. And you pay me directly whatever amount you consider fair for the value you receive. This show is directly listener supported because this business structure ensures that you are my customer, not the companies and campaigns that fund the vast majority of our information sources these days. And I do understand that especially in an election season, it sucks to be hit up for money all the time. It annoys me too. But this show is dependent upon that relationship, our relationship based on trust. And so please do your part if you get value from this episode or from any other episode of Congressional Dish and pay for it, whatever amount you consider fair for the value you receive. All of the ways that you can support the show are on the Support the Show page on congressionaldish.com. And if you do support the show on a regular basis, we have a way for everyone who pays regularly to get a separate audio feed with every one of these episodes, which are uncensored by the golf swing sound effect that we put over all of my dirty words. And that separate feed does have some bonus episodes, most of them non-political. For example, the most recent bonus episode is a 2-hour Ask Me Anything episode featuring my husband and myself answering your questions about how we've been living full-time in hotels as digital nomads and how we afford it. But that's not the main reason to support the show, even though there is some fun bonus stuff back there. The main reason to support the show is because this information matters and it's hard to get. And for some reason, I don't understand it because I find it fascinating, but for some reason, this information about organ transplants in particular isn't being given the attention it deserves in the corporate press. Senator Chuck Grassley of Iowa, as chairman of the Senate Finance Committee, started investigating our organ transplant system 18 years ago, in 2005, which means for 18 years, Congress has been investigating the failures of our organ transplant system. And until I went digging in the congressional record and found these hearings, I had no idea there was a problem. We're being failed by the corporate press, which focuses on politics as opposed to governing. Because any one of us could end up in a situation where we need an organ transplant in order to stay alive. The problems with this system should be known to every American, as thousands of us are dying every year because of this broken system. I find it shameful that I didn't know about this until a few weeks ago. But now I do know about it. And within about an hour, so will you. And so let's get into it. So when I was born in the year 1982, quite a while ago, we had no organized system in the United States for coordinating organ transplants. But in 1984, the National Organ Transplant Act was passed by Congress and signed by President Ronald Reagan. In that law, the Secretary of Health and Human Services was instructed to create a national computerized system for matching patients with organs, referred to as the Organ Procurement and Transplantation Network, or OPTN, which is how you're going to hear it referred to in the hearings. But the Secretary of Health and Human Services would not be creating that national computerized system in-house, as in within the government. Instead, the free marketeers of that era, who operated on the idea that the private sector can do everything better, well, they decided that the network would be created by contract, as in the government would pay a private nonprofit to create our national computerized system for matching patients with organs and manage the network of organ procurement organizations, which you're going to hear referred to as OPOs, and transplant centers, which are located all over the country. The private nonprofit company that would be given the contract, according to the 1984 law, would have 5 main responsibilities. The company would be tasked with maintaining a wait list of people who are in need of organ transplants. The company would match organs to people on the wait list via a computerized system that would operate 24 hours per day, 7 days per week. The company would create rules for and police the participating entities in the Organ Procurement and Transplantation Network, or OPTN. The company would collect and disseminate data about the OPTN network and how it's working. And the company would support the OPTN Board of Directors. Now, here's Senator Ron Wyden. He is the current chairman, the Democratic chairman of the Senate Finance Committee. And he, along with some witnesses, are going to explain how all of the pieces in the network work together.
A 1984 law created the first computerized system to match sick patients with the organs they need. It was named the Organ Procurement and Transplantation Network. Someone needed to manage that system for the whole country, so the government sought to contract an organization to run it. UNOS was the only bidder for that first contract in 1986. The contract has come up for bid 7 other times. UNOS has won all 7. Today, the network UNOS overseas is made up of nearly 400 members, including 252 transplant centers and 57 regional organizations known as Organ Procurement Organizations, or OPOs. Each OPO is a defined geographic service network. A family sitting in a hospital room thinking about donating a loved one's organs does not have a choice of OPOs.
My name is Raymond Lynch. I'm a liver and kidney transplant surgeon and a professor of surgery and public health at Penn State Health and Penn State College of Medicine in Hershey, Pennsylvania. I want to differentiate between organ donation, which is the altruistic decision of the donor patient and their family, and organ procurement, which is the clinical care provided by OPO staff. This is what turns the gift of donation into the usable organs for transplant. Organ procurement is a clinical specialty. It's the last medical care that many patients will ever receive. It's reimbursed by the federal government, and it's administered by OPOs that are each the only provider in the territory to which they hold federal contracts.
My name is Joe Ferreira, and I am the president of AOPO. AOPO is a nonprofit organization that leads the organ donation community through innovation, advocacy, and education to pursue the day when every donation opportunity results in lives saved. One common misconception is that OPOs are solely responsible for the entire donation and transplantation system, when in fact, OPOs are the intermediary entity, and their success is highly dependent on collaborations with hospitals and transplant programs. At the start of the donation process, hospitals are responsible for notifying any OPO in a timely manner when a patient is on a ventilator and meets medical criteria to be an organ donor. Additionally, transplant centers must make the decision whether to accept or decline the organs offered by OPOs.
Right now, patient care delivered by OPOs is some of the least visible in American healthcare. I can't tell you how many patients were evaluated by OPO workers in the U.S. in 2022. I can't tell you how many patients were examined, or how many families were given information about donation, or how many times an OPO worker even showed up to a hospital to do this clinical duty. This lack of information about what OPO providers actually do for patients is the root cause of the variability in rates of organ procurement around the country. My research has shown that what we call OPO performance is a measurable restriction on the supply of organs that results in the unnecessary deaths of patients with organ failure. For example, if the lowest performing OPOs from around the country had just reached the national median over a recent 7-year period, there would have been 4,957 more organ donors, yielding an estimated 11,707 additional organs for transplant. Because many OPOs operate in a low-quality data environment and without appropriate oversight, almost 5,000 patients did not get adequate organ procurement care, and nearly 12,000 other patients did not receive life-saving transplants.
One thing that is clear to me, now that I have watched these hearings multiple times, is that OPOs are not all failures. Some of them are doing a great job speaking to families on the worst day of their lives and procuring organs that will save the lives of others, and doing all they can to match those organs they collect with patients who can use them on the wait list. And some of the people who run those well-run OPOs are going to be some of the people you're hearing testifying today. But what I want to make crystal clear here is that OPOs, in general, are not the enemy. But some of them are failing, and failing badly. Here's Chairman of the Senate Finance Committee, Senator Ron Wyden of Oregon.
Between 2010 and 2020, more than 1,100 complaints were filed by patients and families, staff, transplant centers, and others. The nature of these complaints runs the gamut. For example, in a number of cases, OPOs had failed to complete critical, mandatory tests for matters like blood types, diseases, and infection. Our investigation found one patient died after being transplanted with lungs that a South Carolina OPO marked with the wrong blood type. Similar blood type errors happened elsewhere, and patients developed serious illness. Some had to have organs removed after transplant. Another patient was told he would likely die within 3 years after an OPO in Ohio supplied him with a heart from a donor who had died of a malignant brain tumor. UNOS did not pursue any disciplinary action. In a case from Florida, another patient contracted cancer from transplanted organs, and the OPO sat on the evidence for months.
My name is Dr. Jamie Locke, and I am the director of the Division of Transplantation Surgery at the University of Alabama at Birmingham. In 1 week, I received 4 kidneys from 4 different OPOs, each with basic errors that led to the need to throw away those life-saving organs. One due to a botched kidney biopsy into the kidney's collecting system, another because of a lower pole artery that had been cut during procurement that could have been fixed if someone involved had assessed the kidney for damage and flushed it before packing, but that didn't happen. 2 others arrived to me blue, meaning they hadn't been flushed either.
In total, our investigation found that between 2008 and 2015, 249 transplant recipients developed a disease from transplanted organs. More than a quarter of them died.
And in the Senate Finance Committee report, there were more shocking examples of process failures at some organ procurement organizations or OPOs. So, for example, in June of 2020 in Indianapolis, a kidney was accidentally just thrown in the trash, and because it was no longer sterile, it couldn't be used. In February of 2017, also in Indianapolis, a donor's heart was still beating when the surgeons went to take that person's organs. The surgeons waited 10 minutes for the heart to stop and then took the organs. And in November of 2018 in Miami, Florida, a patient's organs were removed before the heart stopped beating against that family's wishes. And those are the stories that I think every one of us is afraid of when we make the choice of whether or not to put the organ donor sticker on our driver's licenses. The fear that I have heard from multiple people, and I must confess I had myself, is that if they see that sticker, they'll be more inclined to use me as an organ donor instead of trying to save my life. And I always thought that it was a tall tale that people have ever had their organs removed before they were dead, but nope. It's happened at least twice in the last 6 years. And to be completely honest with you, I really struggled with the decision about whether or not I should even tell you this stuff from the report. Because I did think about leaving this information out in order to discourage people from opting out of putting the sticker on the driver's license. And for what it's worth, I'm keeping the sticker on my driver's license, the one that organizes organ donation, and I have no intention of removing it. But I don't think it's a good idea to hide inconvenient information from you. Hiding information is not the solution to this. The solution is to demand a system that doesn't allow these kind of mistakes to happen in the first place, which means that the OPOs need proper policing. So there are punishments that discourage them from ever making these mistakes again. And that policing is UNOS's job. But it's not just process mistakes that are happening and costing people their lives at OPOs. The transportation of organs from donor to waiting list patient is a problem too. And just so you know, in this upcoming testimony sequence, you're going to hear questions posed by Senator Ron Wyden of Oregon and Senator Todd Young of Indiana.
My name is Dr. Jamie Locke, and I am the director of the Division of Transplantation Surgery at the University of Alabama at Birmingham. Imagine having a medication you need to live being thrown away simply because someone took too long to get it to you. Your life quite literally in a trash can. Organs are no different. They too have shelf lives, and they are measured in hours.
My name is Seth Karp, and I'm the director of the Vanderbilt Transplant Center in Nashville, Tennessee, and Surgeon-in-Chief at Vanderbilt University Medical Center. We have 10 hours to get a liver from the donor to the recipient and about 1 hour to sew it in. For a heart, we have about 6 hours. Time matters.
So if you take UNOS's Organ Center, they have a very rigid system, for example, for finding flights and lack either an ability or interest in thinking outside the box. So, for example, if there are no direct flights from California to Birmingham, Alabama, instead of looking for a flight from San Francisco to Atlanta, understanding that a courier could then pick it up in Atlanta and drive it the 2 hours, they'll instead put it on a flight from SFO to Atlanta and allow it to go to cargo hold overnight, where it literally is rotting, if you will, and we're putting extra time on it.
Let's make sure everybody gets this. You're saying you've seen instances of something being put in cargo hold when it is very likely to rot.
That is correct. So if the kidney arrives after 10 p.m. at the Atlanta airport, it goes to cargo hold. We discovered that and made calls to the airlines ourselves. And after several calls to the airlines, of course, they were mortified, not understanding that that was what was happening, and actually had their manager meet our courier, and we were able to get the kidney out of cargo hold. But this went on before we figured out what was happening, because essentially they fly it in, it sits in cargo hold, it comes out the next morning to catch the next flight. Instead of thinking outside the box, if we just get it to Atlanta, it's drivable to Birmingham. And those hours make a big difference. In 2014, I received a kidney that arrived frozen. It was ice cube you could put in your drink. The intended recipient was sensitized, meaning difficult to match. The only thing we could do was tell the waiting patient that due to the lack of transportation safeguards, the kidney had to be thrown in the trash, the final generous act of a donor in Maryland. In 2017, I received a kidney that arrived in a box that appeared to have tire marks on it. The box was squished and the container inside had been ruptured. We were lucky and were able to salvage the kidney for transplant. But why should luck even play a role?
Next will be Mr. Barry Friedman.
I currently serve as the executive director of the Advent Health Transplant Institute, one of the busiest centers in the United States, having performed nearly 5,000 transplants. Organ transportation is a process left to federally designated organ procurement agent organizations, OPOs. Currently, they develop their own relationships with couriers, rely on airlines, charter flights, ground transportation, and federal agencies to facilitate transportation. In many cases, organs must connect from one flight to another, leaving airline personnel responsible for transfers. While anyone can track their Amazon or FedEx package, there is currently no consistent way of tracking these life-saving organs. Currently, there is no requirement for OPOs to use tracking systems.
My name is Brian Shepard. I'm the CEO of UNOS, the mission-driven nonprofit which holds the federal contract to serve as the U.S. organ donation and transplant network. UNOS does not coordinate transportation or track organs in transit. We do provide a service that OPOs can use to use GPS trackers. Some OPOs use ours and some use other commercially available products.
So why is it that, and how does UNOS plan to optimize organ delivery if you don't have 100% visibility into where they are at any given time?
I think that the GPS products that we offer and that other people offer are valuable, that do help in the delivery of kidneys. Only kidneys travel unaccompanied, so this is a kidney issue. But I do think the GPS trackers are valuable, and I think that's why you've seen more and more OPOs using them.
Ms. Brockmeyer, UNOS has developed this organ tracking system. Do you all use it? And I'm curious what you think of it.
My name is Diane Brockmeyer, and I'm the president and CEO of Mid-America Transplant, the organ procurement organization serving Eastern Missouri, Southern Illinois, and northeastern Arkansas. We did use and participated in the beta pilot through UNOS and made the decision to not move forward using their product and have sought a commercial alternative.
And why was that?
Part of the issues were some, service-related issues, the lack of the interconnectivity that we wanted to be able to facilitate, a more expedited visual tracking of where the organ was.
Was the tracking technology low quality?
Yes, sir.
So, in summary, UNOS, the privatized police force for the organ transplant network, doesn't require kidneys to be escorted by a human being, doesn't require any kind of digital trackers on those kidneys, and hasn't built a reliable tracking system for the OPOs to use even if they wanted to. Which I find unacceptable, because as the manager of the computerized network ordered by Congress in 1984, wouldn't you think that using computers to track organs would be a part of that computerized system? Isn't managing the movement of organs from one person to another the central purpose of such a network? And it's bad enough that UNOS is failing to even try to manage the transportation part of that equation. The tech problems apparently don't stop there. They're also screwing up the organ transplant waitlist.
My name is Laquea Goldring. I am currently dependent upon the U.S. organ donation system to save my life while I await a second kidney transplant. As a toddler at the age of 3, I was diagnosed with a rare kidney cancer that took the function of my left kidney. And when I was 17, I went back into complete renal failure, and I received a first kidney transplant at that time. Unfortunately, in 2015, I went back into kidney failure, and at that time, I wasn't ready for another transplant, but I didn't have a choice but to go back on dialysis. I've been waiting 9 agonizing years for a transplant, dependent upon a dialysis machine 5 days a week just to be able to live. I was told that I would receive a kidney transplant within 3 to 5 years, but yet I am still waiting. I'm undergoing monthly surgeries just to be able to get my dialysis access to work so that I can continue to live until I get a transplant. The UNOS wait list is not like 1 to 100 where everybody thinks you get a number. I'm never notified on where I stand on the list or when I will get the call. I have to depend on an algorithm to make the decision of what my fate will be. Just a few weeks ago, a donor family had reached out to me to be a directed kidney donor, meaning they chose me specifically for a kidney transplant. But unfortunately, due to their errors in the UNOS technology, I was listed as inactive, and this was a clerical error. And all that they told me was this was a clerical error, and they could not figure out why I was inactive. But when it came down to it, I'm actually active on the transplant list.
My name is Diane Brockmeyer, and I'm the president and CEO of Mid-America Transplant, the organ procurement organization serving eastern Missouri, southern Illinois, and northeastern Arkansas. We must update the archaic technology system at UNOS. As OPOs, we are required to work with UNOS technology DonorNet every day. DonorNet is outdated, difficult to use, and often slow to function when every minute counts. Manual entry subjects it to error, and OPO and transplant center staff are not empowered with the right information when time is critical. I did serve in leadership roles on the OPO committee from 2017 to 2022. Committee members and industry leaders voiced repeated requests to improve DonorNet. The consistent response was UNOS IT did not have the bandwidth to address this work. The limitations of the UNOS technology are delaying and denying transplants to patients that are dying on the wait list. Poor technology impacts the disturbingly high kidney discard rate in the United States, where 1 in 4 kidneys never make it to a patient for transplantation.
My name is Dr. Jamie Locke, and I am the director of the Division of Transplantation Surgery at the University of Alabama at Birmingham. Obviously, people have described that we have about a 25% kidney discard, so 1 in 4. So if you look at numbers last year, these are rough numbers, but that'd be about 8,000 kidneys. And really, I think in some ways, these were kind of a victim of an entrenched and cumbersome allocation algorithms that are very ordinal. You have to go sort of in order when data clearly have shown that introduction of multiple simultaneous expiring offers would result in more efficient placement of kidneys, and this would decrease our cold ischemia time. And if you think about IT, something as simple as having a system where we can more easily put in unacceptable antigens. This was a debate for many years. So for context, we list unacceptable antigens in this system. It allows us to better match kidneys so that when someone comes up on the match run, we have a high probability that they'll be a good tissue match. Well, that took forever, and we couldn't really get our unacceptable antigens in. So routinely, people get offered kidneys that aren't going to be a match, and you have to get through all of those before you can get to the person that they really should go to. Those are simple examples, but if we could really have transparency and accountability around those kinds of things, we could save more lives.
Next will be Mr. Barry Friedman.
I currently serve as the executive director of the Advent Health Transplant Institute, one of the busiest centers in the United States, having performed nearly 5,000 transplants. UNOS is not effectively screening organ donors so that they can be quickly directed to transplant programs. UNOS asks centers to voluntarily opt out of certain organs via a filtering process. As a result, OPOs waste valuable time making organ offers to centers that will never accept them. Time wasted equates to prolonged cold ischemic time and organs not placed, resulting in lost organ transplant opportunities.
Of course, an available organ should be offered to the patient in list sequence. However, far too much of the matching, particularly on older donors and organs that are difficult to place, are left to the individual OPOs and transplant centers to find each other, despite rather than facilitated by UNOS technology. Mid-America Transplant intentionally identifies surgeons who accept kidneys that have been repeatedly turned down many times. These are life-saving options for those patients. In May of 2022, one of these patients was number 18,193 on the list. Relying on DonorNet alone, that kidney would never have been placed, and the chance to save a life would have been wasted.
So UNOS isn't even pretending to be coordinating the transportation of organs from one person to another. And the computerized network, which is the basic function that they're paid to create and maintain, is apparently crap. And the CEO of UNOS is not displaying any intention of upgrading the system to meet the needs of the network. Here's Brian Shepard, the CEO of UNOS, speaking to Senator Ben Cardin of Maryland.
The OPTN IT system that UNOS operates has 99.99% uptime. It is a highly reliable system. We are audited annually by HRSA.
My information shows it had 17 days down since, I think, 1999. That's not correct?
In 23 years, yes, sir.
Okay, well, every day there is a loss of life, isn't it?
That's the total amount of time over the course
I hope that
of
our national defense system isn't down 17 days a year.
The system has never been down for a day. And to my knowledge, and I have not been at UNOS since 1999, but to my knowledge, there's been maybe one event that was longer than an hour, and that was 3 hours. But the total amount of time since 1999.
So you're satisfied with your technology. You think you had the right technology. You're satisfied with your tracking systems now. You think everything is okay?
We constantly improve our technology. We're subject to 3 million attempts a day to hack into the patient database, and we successfully repel them all. So we are never satisfied with our technology, but we do maintain 99.99% uptime. We disagree with the USDS analysis of our systems.
My name is Molly McCarthy, and I am an exceedingly grateful 3-time kidney transplant recipient after having had my first transplant 32 years ago. Further, I have been called by a board member telling me to stop focusing on system outage and downtime of the UNOS tech system. He told me that having downtime wasn't a big deal at all. The donors are dead anyway. That comment speaks volumes to me about the lack of empathy and respect UNOS has for donor families.
17 days down over 23 years is 403 hours. And the CEO is talking about that as if it's okay. Their responsibility, according to the law, is to operate a computerized network all the time. And so 403 hours down sounds like too many to me. And the USDS report that he mentioned, the one that he says he simply disagrees with and is apparently disregarding, well, that report was written by the U.S. Digital Service, which is an office that's housed within the Executive Office of the President and provides consultation services to federal agencies on information technology. And their report, which is titled Lives Are at Stake, concluded that UNOS is incapable of modernizing the network's IT infrastructure, that the current UNOS system is fragile, disjointed, and creates an inadequate user experience, and that UNOS is resistant to change. And the CEO's defense of the technology system and his focus on their apparent success in stopping hackers, which no one expressed concerns about, his refusal to offer solutions to the concerns about the system's downtime, and, most importantly, his refusal to address the failures to make organ matches efficiently, his defensiveness of UNOS technology makes me think the report probably has it right, because I do believe that UNOS is resistant to change as long as this dude is in charge of it. And when it comes to the effects of all of these combined failures, these failures are affecting some of us more than others. And in this upcoming clip sequence, you're going to hear comments and questions from that congressman who is Representative Andrew Clyde, who represents a district in the southeastern United States in the state of Georgia.
My name is Dr. Jamie Locke, and I am the director of the Division of Transplantation Surgery at the University of Alabama at Birmingham. One of the most important things that we don't currently do is we don't actually account for disease burden in terms of examining our waiting list. So we have no way of knowing if we're actually serving the correct people, if the correct people are actually making it to the waiting list. Disease burden is super important because it not only identifies the individuals who are in need of transplantation, but it also speaks to supply. So areas with high rates of end-stage kidney disease burden, like the southeastern United States, are going to have much lower supply. And they also are those waiting lists predominantly consist of African-American or Black individuals.
You know, I'm a little disappointed that we're discussing race as a factor in organ transplant. We're all one race, in my opinion. Color makes no difference to me. We're the human race. And to me, the interjection of race into this discussion is very concerning. Discrimination based on race was outlawed almost 60 years ago through the Civil Rights Act of 1964. Now, I'm not a medical doctor, and I have very little knowledge of medicine. But last year, there was an article that came out in Life Source, and it says, does my race and ethnicity matter in organ donation? And so my question here is for Dr. Karp. In your experience, would you agree that a donor's organs are more likely to be a clinical match for a recipient of the same ethnicity? Could you comment on that? Is that actually a factor or not? I mean, we're all human beings. We're all, have similar bodies.
My name is Seth Karp, and I'm the director of the Vanderbilt Transplant Center in Nashville, Tennessee, and Surgeon-in-Chief at Vanderbilt University Medical Center. Yeah, so there definitely are certain HLA types that are more common that is race-based. So the answer to that question is yes.
Okay, all right. And so if you have more of one particular race, more donations of one particular race, then naturally you would have more actual matches of that particular race. Is that correct?
That would tend to be the case.
Okay, all right. That's just a question that I wanted to clear up here.
My name is Anna Cryer, and I am the CEO of the Global Liver Institute. We know that from many studies that Black and brown communities donate organs in the same percentage they are of the population. So it is not a problem of willingness to donate. It is a problem about UNOS and OPO, not ensuring that OPOs go out into the communities, develop relationships far before that horrible decision is needed to made to donate the organs of a family member.
So if you want to make a truly equitable organ system, you have to essentially get more organs to those areas where there are higher disease burdens. I think the other thing is that we have to have more focus on how we approach donor families and make sure that we have cultural competence as a part of our OPOs and how they approach families to ensure that we're not marginalizing minority families with regard to the organ donation process.
We would like to see investments in languages that are spoken by the community. Educational resources should be, as required by law, for those with English, limited English proficiency. They should be in the languages spoken by the community. They should be hiring diverse staff to have those most crucial conversations with families. The data shows, and certainly experience and common sense shows as well, that having people of color approaching families of color results in more donations.
Those are actionable, reasonable suggestions for fixing the problem of inequality in organ procurement, even if people like Representative Andrew Clyde of Georgia want to pretend like biologic differences between races and ethnicities aren't a thing worth even discussing. But anyway, in summary, some OPOs are struggling to safely and efficiently collect organs to be donated and to get them where they need to go in a timely manner. And UNOS is doing a terrible job coordinating all of this via the computerized network that they get paid by us taxpayers to manage for the government. So who's holding any of these organizations accountable for their failures? Well, let's start with accountability for the OPOs, because figuring out which OPOs are the problem OPOs and what exactly needs to be fixed within them, that's not easy because of the way the network itself is structured. And so in this upcoming clip sequence, in the second half of it, you're going to hear questions and comments by Senator Elizabeth Warren of Massachusetts, Senator Todd Young of Indiana, and Senator Ron Wyden of Oregon. And in this conversation, you're going to hear mention of CMS, which stands for Centers for Medicare and Medicaid Services, which is the part of our government that is in charge of all of this.
My name is Seth Karp, and I'm the director of the Vanderbilt Transplant Center in Nashville, Tennessee, and Surgeon-in-Chief at Vanderbilt University Medical Center. Last year, I had the opportunity to co-write a viewpoint in one of the journals of the American Medical Association with DJ Patel, former Chief Data Scientist of the United States. In that article, we provided evidence that the metrics used to judge the performance of organ procurement organizations were basically useless. Until the recent OPO final rule, performance was self-reported, and OPO employees admitted to having gamed the system. When threatened with decertification, one of the OPOs themselves successfully argued that because the performance data were self-reported and unaudited, they failed to meet a reasonable standard, and the OPO should not be held accountable. In other words, for decades, the metrics supposed to measure performance didn't measure performance, and the results have been disastrous, as you have heard.
My name is Raymond Lynch. I'm a liver and kidney transplant surgeon and a professor of surgery and public health at Penn State Health and Penn State College of Medicine in Hershey, Pennsylvania. OPO clinical work is currently not visible, it's not benchmarkable, and it's not able to be adequately evaluated, analyzed, or compared. However, much of the hidden data about how OPOs provide care to patients is known to one entity, and that entity is UNOS.
My name is Diane Brockmeyer, and I'm the president and CEO of Mid-America Transplant, the organ procurement organization serving eastern Missouri, southern Illinois, and northeastern Arkansas. When an OPO goes out of sequence to place an organ that would otherwise be thrown away, UNOS requires an explanation. However, when organs are recovered and discarded, UNOS remains silent. UNOS lacks urgency and accountability around identifying and remediating this preventable loss of organs, and they are not required to publicly report adverse events when patients are harmed, organs are lost, or the quality of patient care is deemed unsafe. UNOS does not require clinical training, licensure, or certification standards for OPO staff delivering critical patient care. In this environment, who's looking out for the patient? Who's being held accountable for poor patient care? No OPO has ever actually been decertified, regardless of its performance or its safety record.
Mr. Shepard, you are the CEO of UNOS, and we have documented these problems, and you've received more than 1,000 complaints in the last decade alone. So tell me, in the 36 years that UNOS has had the contract to run our national organ system, how many times has UNOS declared its OPO members, any OPO members, not in good standing?
2 times, Senator.
How many times has UNOS put an OPO on probation?
I don't that number off the top of my head, but it's not a large number.
It's not large. In fact, it's 3.
Once an OPO is designated not in good standing, Senator Warren referred to this as toothless. It does seem toothless to me. I'll give you an opportunity, Mr. Shepard, to disabuse me of that notion and indicate for me what penalties or sanctions are actually placed on an OPO when they are designated not in good standing.
The statute does not give UNOS any authority to offer sanctions like that. The certification, decertification, payment authorities belong entirely to CMS. UNOS's statute doesn't give us the ability to...
So it is toothless in that sense.
It is designed to be, by regulation and contract, it is designed to be a quality improvement process, in contrast to the oversight process operated by a federal agency. If you're asking whether UNOS can prevent an OPO from operating or from being an OPO, then we cannot.
Well, not prevent them, but require them to do something. You don't have the ability to require them.
The peer review process has significant persuasive authority, but all the payment authority and all the certification, decertification authority live at CMS.
Mr. Shepard has said twice with respect to this whole question of the power to decertify an OPO that CMS has the power to do it. UNOS also has the power to refer an OPO for decertification under the OPTN final rule. That has been done exactly once. So I just wanted it understood with respect to making sure the committee's got what's really going on with respect to decertifying OPOs.
So it seems pretty clear that the OPOs are not being policed because a Congress of the Ronald Reagan free the market to do everything era decided that policing the organ transplant network is a job for a company. And that company is claiming that only the government has the authority to do the policing. And so while everyone's pointing fingers at each other, government to company, company to government, well, for 40 years, that has meant that there's been effectively no cop on this beat. And some OPO managers have been robbing us taxpayers blind in the absence of accountability. Here's Representative Raha Krishnamurthy of Illinois.
Unusual among Medicare programs. Their costs are 100% reimbursed, even costs unrelated to care. So, extravagant executive compensation and luxury perks may be passed off onto the taxpayer.
My name is Tanya Ingram. I am a poet, Cincinnati native, Bronx bred and driven, Los Angeles resident, mental health advocate, cat auntie, Tom Hardy lover, and The Office fanatic, and I need a kidney transplant. The organ procurement organization that serves Los Angeles, where I live, is failing according to the federal government. In fact, it's one of the worst in the country. One analysis showed it only recovered 31% of potential organ donors. Audits in previous years found that LA's OPO has misspent taxpayer dollars on retreats to 5-star hotels and Rose Bowl tickets. The CEO makes more than $900,000. Even still, the LA OPO has not lost its government contract, and it has 5 more years to go.
Mr. Ferreira, I would like to turn to you. You run the OPO called the Nevada Donor Network. I have your OPO's 2019 financial statement filed with the CMS. It appears that your OPO spent roughly $6 million in 2019 on administrative and general expenses. Interestingly, in 2019, I see your OPO spent approximately $146,000 on travel, meetings, and seminars alone. And your itemization of administrative and general has an interesting line item for $576,000 for quote, unquote, A&G. It took me a minute, but that means you have an administrative and general subcategory in your administrative and general category. Very vague. Now, Mr. Ferreira, I was informed by Mr. Wadsworth, a former executive of yours at the Nevada Donor Network, that your OPO has season tickets to the NHL's Las Vegas Golden Knights. Isn't that correct?
That is correct, Mr. Chairman.
And you also have season tickets to the Las Vegas Raiders too, right?
That is correct.
And according to Mr. Wadsworth and others, your OPO took a board retreat to Napa Valley in 2018?
That is correct.
And Sonoma in 2019, right?
That is correct.
Mr. Ferreira, what you're spending on the Raiders, the Golden Knights, Napa Valley, and Sonoma have one thing in common. They have nothing to do with recovering organs.
So it seems clear to me, and I should mention pretty much every member of Congress, regardless of their party, that UNOS is allowing the OPOs to do pretty much whatever they want, and that it's a problem. So UNOS isn't effectively policing OPOs, but who then is supposed to be policing UNOS and busting them for failing to do their job? Well, the Organ Procurement and Transplantation Network, the OPTN, is the only entity other than the government itself which is higher than UNOS in the chain of command. And the OPTN, the network itself, does have a board of directors. So, here's Senator Ron Wyden of Oregon.
All right, let's talk for a moment about the boards that are supposed to be overseeing these, because it looks to me like there's a serious conflict of interest here, and I'll send this to Ms. Brockmeyer, and perhaps you'd like to get to it as well, Mr. Friedman. The Organ Procurement and Transplantation Network, which is the formal title of the organ network that operates under federal contract administered by HHS, and UNOS, which is the contractor that operates the network and controls information about the network, have the same boards of directors, despite efforts by the government to separate them. That means the people who look out for the best interests of UNOS, the multi-million-dollar nonprofit, are the same people who look out for the interests of the entire organ transplant network. Sure sounds like a conflict to me.
My name is Diane Brockmeyer, and I'm the president and CEO of Mid-America Transplant, the organ procurement organization serving eastern Missouri, southern Illinois, and northeastern Arkansas. We must remove conflicts to ensure effective governance. From 2018 to 2020, I served as a board member for the OPTN. Serving on the board of the OPTN automatically assigns membership to the UNOS board. My board experience revealed that at times UNOS actions are not aligned with its fundamental vision of a life-saving transplant for everyone in need. How can you fairly represent the country's interest and a contractor's interest at the same time? Board members are often kept in the dark about critical matters and are marginalized, particularly if they express views that differ from UNOS leadership. Preparatory small group calls are conducted prior to board meetings to explore voting intentions. And if the board member was not aligned with the opinion of UNOS leadership, follow-up calls are initiated. Fellow board members reporting feeling pressured to vote in accordance with UNOS leadership. I think there should be an independent board. I think the division of the responsibilities of the board and by the inherent way that they're structured do pose conflicts. It would be like if you had an organization that was a supporting organization, you'd want to hold it accountable for its performance. And the current structure really limits that opportunity.
And that suggestion was echoed by others. In fact, the witnesses who gave their suggestions to Congress were pretty consistent with each other in their requests to Congress. And so here is the suggestions of the following experts. You're going to hear from Dr. Jamie Locke, the transplant surgeon from Birmingham, Alabama. You'll hear from Diane Brockmeyer, the president and CEO of the competent OPO serving the St. Louis, Missouri region. You'll hear from Barry Friedman, the executive director of Advent Health Transplant Institute. You'll hear from Matt Wadsworth, the president and CEO of Life Connection of Ohio, which is an OPO that everyone seems to agree is performing well for the people of Ohio. You'll hear from Dr. Raymond Lynch, the professor of surgery and director of transplantation quality and outcomes at Penn State Health Medical Center. And finally, you'll hear from Molly McCarthy, the vice chair and Region 6 Patient Affairs Committee representative in the Organ Procurement and Transplantation Network.
Number 1, immediately separate the OPTN board from any of the boards of any contractors. Number 2, bring in real experts to ensure our patients are served by the best of the best in each field, separating out key functions of the OPTN, including policy, technology, and logistics. And number 3, ensure that patients are safer by holding all contractors accountable through public adverse event reporting and immediate redressing of problems.
To protect patients, I urge Congress and the administration to separate the OPTN functions into different contracts so that patients can be served by best-in-class vendors, to immediately separate the boards of the OPTN and OPTN contractors, and to ensure that patients are safeguarded through open data from both the OPTN and OPOs.
Due to the limited expertise that UNOS has in the placement of organs, it would be best if they were no longer responsible for the development of organ placement practices.
Break up the OPTN contract and allow for competition.
We need a new network of highly skilled specialist organizations, each attending to areas of expertise in the management of the OPTN contract.
Congress needs to break up the UNOS monopoly by passing 1668, ensuring that HHS uses its authority to replace UNOS as its contractor.
The bill that she wants passed is the Securing the U.S. Organ Procurement and Transplantation Network Act. Now, this bill requires that the board of directors of the network and the board of directors of the companies that get the contracts are not the same thing. And second, the bill expressly authorizes the government to award multiple grants, contracts, or cooperative agreements to support the operation of the OPTN, the Organ Procurement and Transplantation Network. In other words, the bill authorizes the government to take the contract to operate the network away from UNOS and break it up into multiple contracts that will be allowed to be given to government, nonprofit, or private for-profit entities. Here's Senator Elizabeth Warren of Massachusetts explaining the rationale behind that decision in the bill.
And among the many reforms, the legislation would support HRSA's proposal to break up the OPTN monopoly contract into multiple smaller contracts, which would allow some competition and allow the best vendors in the business to manage different parts of the transplant network operation. That means hiring IT experts to do the IT. It means hiring logistics experts to do logistics, and so on. Right now, Congress has an opportunity to root out corruption in this system. But if we don't act before the current contract expires, we won't have another shot for years.
And Congress has acted. The Securing the U.S. Organ Procurement and Transplantation Network Act passed the House of Representatives at the end of July, followed by the Senate 2 days later. Both votes were voice votes, meaning that they were unanimous yes votes. And as of this recording, the bill is sitting on President Biden's desk waiting to be signed. And I'm assuming that it's going to be signed into law, hence why I went forward with this episode. But if for any reason it isn't, I'm definitely going to pop back in and do a bonus episode letting you know, because that would be extremely surprising. But I do have to say that even though this was a unanimously passed bill, there were some concerns raised about it that I think are worth noting. So here's Senator Marsha Blackburn of Tennessee speaking to Dr. Raymond Lynch, the professor of surgery and director of transplantation quality and outcomes at Penn State Health Medical Center.
When we look at OPTN and look at the Securing Organ Procurement, the Act, the bill would strip the nonprofit requirement for the manager of the Organ Procurement and Transplantation Network, which would open the door for profiting from organ procurement and donation. And to me, this is something that I think many people really fear, especially people that are on a wait list. And so what I would like for you to do is to address that and address those concerns and why or why not you think the Act has it right.
Thank you, Senator. I think it's unfortunate that people would be afraid of that, and it needs to be changed. Many of the patients that you reference are waitlisted at for-profit hospitals. For-profit is a part of American healthcare, and I can tell you that our not-for-profit entity, UNOS, doesn't work, and there are for-profit hospitals and for-profit transplant centers that do work. So patients don't need to be afraid of that. They do need to be afraid of the status quo.
Which is not an answer that I found particularly comforting as someone that's generally suspicious of the private sector, especially the for-profit private sector, handling what should be essential government functions. Because in most other countries, healthcare is considered an essential government function, which I define as something that everybody needs on standby, which is impractical to fund as individuals. Because it's unreasonable to expect individuals to be able to pay for heart surgeons and brain surgeons and trauma surgeons and nurses and anesthesiologists and organ transplant surgeons and all of the other people who may be needed in case you get in an accident or have an illness. It's unreasonable to expect that each of us individually could fund our own healthcare teams to be on standby for the chance that we might need them. Healthcare is a system. And it's a system that is essential to life. And most other governments have not privatized their health systems the way we have. Our system has resulted in us having the most expensive healthcare in the world with subpar results. And so the idea that the organ transplant system should be privatized like the rest of our privatized healthcare system, it's not convincing for me. But that said, here's Senator Elizabeth Warren of Massachusetts.
UNOS does not want to lose control. So they're pushing to have the government limit eligibility only to nonprofit vendors that have worked in the past on organ donation. Meaning, for instance, that the IT company that is hired to run OPTN's computer systems would have had to have worked on an organ transplant network in the past and be a nonprofit. So, Ms. McCarthy, the requirement UNOS wants would seem to make it so that only one organization could apply for the new contract, UNOS.
And preventing that situation by making for-profit companies eligible for the organ procurement and transplantation network contracts makes a lot of sense to me. Because I do see how private companies could be useful here when the contract is broken up into pieces. And I keep thinking about the transportation problems, for example. A private company could be invented specifically to transport organs around the country, one that has human beings escort all those organs, including kidneys, to their destinations. Now, even if they're making a profit, and even if that profit is funded by taxpayer money, if they do a good job, I would want a company like that to get that contract. We could also have a company that's created, for example, online dating apps to create the waitlist system, matching organs with proper blood types the way that they can match people based on what dumb things they like to do on the weekends. And a different entity, perhaps a government one, could be given the contract for policing the OPOs, with financial incentives built in for saving taxpayer money by catching and reporting for decertification OPOs that do things like buy themselves Raiders season tickets and lose vital internal organs. Because while transportation and the technology do seem like functions that can be effectively outsourced to the private sector, policing anyone, but policing specifically the participants in the network seems like an essential government function to me. I don't love the idea of inserting a for-profit middleman into the process when we could just have government regulators do the regulating. Like, why should we have to pay for tattletales to the government when the government can just do the policing directly? It seems like an expensive middleman that we don't need. But overall, because the contract is going to be broken up, and because the experts told Congress that this would make a big difference in a positive way, I'm inclined to see this bill becoming law as good news. It's good news that UNOS is being fired. It's good news that experts see a path to a better network with these changes. It's good news that Congress has already acted because the contracting process is starting this fall. And it's good news that Congress did this in a refreshingly bipartisan way. There was not a hint of partisanship in any of these hearings going back years. And not a single member of Congress stood in the way of this bill in its journey to the president's desk. And here's the best news of all.
My name is Seth Karp, and I'm the director of the Vanderbilt Transplant Center in Nashville, Tennessee, and Surgeon-in-Chief at Vanderbilt University Medical Center. In 2019, there were 6 heart transplants that were performed using donors after circulatory determination of death. And I don't want to get into the technical aspects of that, but in 2019, that number was 6. In 2020, that number was 126. This is a new technology. This is a way that we can increase the number of heart transplants done in the United States dramatically. And if we think that there were 500 patients in the United States waiting for a heart in 2020, 500 patients that either died or were delisted because they were too sick, and you think in 1 year using a technology, we got another 100 transplants. If we could get another 500 transplants out of that technology, we could almost eliminate deaths on the heart transplant waiting list. That technology exists. It exists today, but we don't have a mechanism for getting it out to everybody that could use it. And it's gonna run itself through the system. It's gonna take too much time. Whenever I, or quite frankly, most everyone else in the field gives a talk on transplantation, we usually make 2 points. The first is that organ transplantation is a miracle of modern medicine. The second is the tragedy that there are not enough organs for everyone who needs one. I no longer use this second point because I don't believe it. Based on my work, I believe that there are enough organs for patients who require hearts, lungs, and probably livers, and we can make a huge improvement in the number of kidneys available. In addition to improving OPO performance, new technologies already exist to dramatically increase the organ supply. We need a structure to drive rapid improvement in our system.
And when the Securing the U.S. Organ Procurement and Transplantation Network Act becomes law, that structure is at least possible. It's certainly more possible than it would have been had Congress done nothing and had UNOS been allowed to continue managing the system. And this is why I love Congress. Despite all the madness and the disgusting political games, real good happens in Congress. Real good that can and does save lives happens there. The potential of our Congress is enormous. And I'd like us to keep that in mind, especially over the next few months, because a small group of Republicans in the House of Representatives is poised to tarnish the reputation of Congress even more so than it already is over the next few weeks and months. Because as I record this, we are barreling towards another government shutdown. And I actually wouldn't be surprised if the government shuts down more than once over the next few months, because Congress has finished exactly 0 out of the 12 government funding bills that are due on the president's desk by the end of this month, which means that Congress needs to extend the deadline. And there's a small group of House Republicans who, this is where I would ordinarily tell you what they are demanding, but honestly, it's not clear to me what they want specifically. But all I know is that they are threatening to use the leverage that they have in the House of Representatives to prevent any extension of government funding from being passed. They say they want the spending bills to be passed using regular order, as in all 12 of them passed, but they're blocking those spending bills from going forward. So I don't understand what they want here. It's a total mess, and it's impossible to predict what's coming, but it's definitely not an exhibit of good governance. That much is certain. But what I want you to know is it doesn't have to be this way. Congress can make our lives better. Congress can make our country safer, and not just militarily, but by using lawmaking power to create efficiently operating systems for things like organ transplants. In that capacity, Congress can save lives. And if we choose to elect more people to Congress who prioritize issues like this, as opposed to prioritizing using their power to punish the other political team, or to seek media attention for themselves, or to enrich themselves using lawmaker knowledge in the stock market, or to line up fancy consulting jobs after they get out of Congress, or lobbying jobs, or, we have a lot of selfish people in this Congress. And if we fire the people who do those things and elect people who are serious about governing and less interested in political warfare, we can solve all of our national problems using the power of Congress. And so let's remember that in the upcoming months. Government can be a force for good. And for the over 100,000 Americans who are waiting for an organ, Congress just did something good for them. Something good for us. Congress is changing a broken system, and that will likely save American lives. So this is the second recording of this episode. The first one that I recorded, I just wasn't happy with for 2 reasons. First of all, I was using a new microphone, and even though I have been told by people I absolutely trust with these judgments that the sound quality wasn't that bad and that I could air the episode, it's just been eating at me. And so I decided to re-record this one. So this version is a little bit different from the first, mainly because sometimes I go off script. And so there were comments I made in the first episode that I don't even remember and didn't make in the second. But the original episode, if you want to hear it, because I do know that in the first one, I talked a little bit of trash on Representative Andrew Clyde, and I meant every word of it. But if you want to hear the original version, I'm keeping that up on the Green Room feed, which is the separate audio feed for people that pay for this show. So if you want to hear that, it's still available for those of you who pay for this show. And then the second reason that I re-recorded this is this episode was making damn near no money. I'm pretty used to, after I release a new episode, getting the Venmos and the Zells and the people that pay, whenever they like an episode. There are people that don't contribute regularly, but just send in these one-time payments. And I've gotten exactly 2 of them. And so I don't know if I have to imagine it's the sound quality. I don't really know. This is the type of anxiety that I get, but when I don't get paid for my work, I wonder why. So I'm recording this hoping that the better sound quality will help, because I think this is a good episode. I think this stuff was so interesting, and I refuse to believe that this episode was crap. So yeah, so that's why I recorded this a second time. And that is that. But before I wrap this up, again, this is a listener-supported podcast, and we're coming into the busy season here. There's going to be some crazy stuff coming in Congress. I am feeling the financial anxiety about this. I'm feeling the anxiety about what's coming for the country and what this Congress is going to do. And it is my job to pay attention to it and to make episodes for you about it. But this is the time of year that this job gets hard, especially when I just know that there's going to be a lot of irrational things happening and irrational things that I can't control. And so I can really use some support right now. And I hate saying this, because the people that are paying for the show via Patreon or PayPal or Zelle, all of you that are contributing regularly, like, you are keeping this podcast going. And I know that you're there, and I appreciate you so much. But I have noticed that since I stopped doing thank you episodes, the people that pay on Zelle or PayPal, or especially the Venmos, the people that just send in money whenever, a lot of those people have stopped paying for the show. And I find it disheartening that happened, because it feels to me like those people weren't really paying for the show. They were paying just to hear their own opinions on the air, maybe. Like I said, I'm having anxiety about it. So please support the show. And I will continue to do this, even though the next few months they're going to be something. They're going to be something. So yes, please pay for the show. That's what I'm asking for. But some people do pay for the show, and Sage Felker is one of them. Sage, thank you so much for all of your support over the years. And Sage is now going to be an executive producer on not 1, not 2, but 3 of our episodes. And that means that Sage has contributed $535 per episode. Every time you contribute $535, whether it's a lump sum $535 or it's cumulative over the months and years, you get to put your name on an episode that you are particularly proud to have helped produce. You are listed down as an executive producer on congressionaldish.com on that episodes page, but also we have a page called the Most Valuable Episodes page, and that is determined by you. I've been asked so many times over the years, like, you have all these episodes. At this point, we have 281 episodes of Congressional Dish, and people don't know where to start. And that is you. That is the people that are funding this show, saying these are the episodes that are most valuable to me, to the point that I am paying for a significant portion of their production. So that's what the executive producers are. And every time we put an executive producer credit on an episode, it moves up the list. And Sage has now caused 3 episodes to move significantly up the list. All 3 of these episodes are now on the front page of the Most Valuable Episodes list because of Sage Felker. So the 3 episodes that Sage has picked are episode 228, the second impeachment trial of Donald Trump. Now that episode, I watched all of the trial and the evidence that was presented in the second impeachment. That was the impeachment that was done a couple weeks after January 6, 2021. And that is when the Democrats, who were the ones in charge of the impeachment, decided to focus entirely upon the riot without having done an investigation into what actually happened on January 6th. And I think that's a really important episode because as the president, ex-president, Donald Trump is going through the legal process for the events of January 6th, there was so much more to what happened that day beyond the riot. The riot was really just a sideshow. There were efforts that started on Election Day and went through January 6th. And the effort was to keep Donald Trump as president by using fake documents from 7 states that said that Donald Trump won when he had actually lost. And the efforts that these people had to go through together to fake those documents, it required them getting dozens of people, either tricking them or getting willing participants who, by the way, are being prosecuted for this too. But they had to get dozens of people to meet in order to sign these documents saying that Donald Trump won when he didn't. And then they transmitted those to the government as if they were real. And the plan on January 6th was to get Mike Pence to use those fake documents to cause enough chaos in the vote count that either the House of Representatives would do the voting for president, which is what the Constitution basically says would happen if you can't do it the right way, in which case the Republicans would have had the votes needed had they voted in lockstep to make Donald Trump the president. Or, I mean, there was a couple different things they wanted to happen, but the point that I want to make here is that they were trying to use fake documents to make Donald Trump president. And when the second impeachment trial happened, because the Democrats impeached first and investigated second, they didn't know about any of that. So there are a lot of people making the case now that had Donald Trump done anything wrong, well, then he would have been impeached and been disqualified from office. But the way that was done, in that episode, said that I would have acquitted Donald Trump for the accusations that were made in that second impeachment trial. So I think it's really important to understand what happened in that trial and how different the evidence presented there is from the evidence that's going to be presented in the state of Georgia and in the federal case against Donald Trump. So that's a great episode to pick. Thank you so much for moving that up the list. Sage also decided to put an executive producer credit on Target Belarus, which is a very relevant episode considering that we are still very much involved in the war in Ukraine. And this upcoming, most likely, government shutdown, Ukraine is likely to be a part of this because the president and many members of Congress want $25 billion more for the war in Ukraine. They're tying that to, I think, $16 billion in FEMA money because we've had a hurricane and Lahaina on the island of Maui has burned to the ground. And so Americans, for, I think, obvious reasons, want our tax money to go to help Americans who have suffered like this. But they want even more money than we want to give to our own American people to go to Ukraine. So there are some political problems with that. And when it comes to Belarus, Belarus is a partner of Russia's in that war. Now, what's fascinating about my episode, Target Belarus, is that that episode was created before Russia invaded Ukraine. I saw some provisions in the National Defense Authorization Act that were essentially authorizing regime change actions towards Belarus before the war. And so now that they're partnered with Russia, I just think listening to that episode will help you understand that partnership a little bit better than you might have understood it without listening to the episode. Because I know I think about that episode a lot. And then on the subject of the Ukraine war, the third episode that Sage has picked for the executive producer credit is episode 248, Understanding the Enemy. And that episode I produced right after the war started. And that is an episode that features the words of Vladimir Putin explaining why he says he invaded Ukraine. Because we're told a lot about the mind of Putin, but from Americans. But I wanted to hear from Putin himself. Why did you do this? And so I took his speeches, got them translated, and you're going to hear them. Well, I didn't get them translated, but you're going to hear the translations yourself if you want to understand why he says he started that war. Because at this point, and that's the other thing too, I have been looking through all of the hearings that have happened for the past few months. There's this counteroffensive that we've been funding. I mean, we've been funding everything that's been happening in Ukraine. But there was this counteroffensive. There was supposed to be this big movement by Ukraine to reclaim territory over the summer months before the winter started. And that counteroffensive has been going on. And I'm trying to find hearings for you so that we can get an update on how it's going. And they're just not having any hearings. So here they want $25 billion from us, but they're not having any public hearings. And I'm pretty sure the reason that they're not having any public hearings, knowing that these people all support the war and want the $25 billion, the reason they're probably not having hearings is because the counteroffensive isn't really working. The Ukrainians are able to take back a few fields here and there, but for the most part, the lines of what is controlled by Russia and what is controlled by Ukraine really hasn't moved in the last few months, which means this whole idea that we're going to fund Ukraine until victory. Well, unless we personally get involved, unless the Americans are willing to go in or NATO's going to go in and fight this for Ukraine, it's not looking like Ukraine's going to be able to do it on their own. And these are conclusions I'm making by looking at maps and watching international news. But I do think it's really disturbing that our Congress isn't even having hearings and yet they're still going to fund this thing. Yeah, there's some problems. And this is going to be a part of the upcoming funding battles and possibly the government shutdown. So those are really good episodes that you picked. Sage, thank you so much for moving them up the list. And if you are someone who has a favorite episode and you don't see it on the front page of that list, I can tell you that we only have 5 episodes that have 3 executive producers or more. And so if the episode that you like has 2 or even 1 executive producer, you can make some major moves on them by putting EP credits on them, just as Sage has done. So, but thank you again for supporting the show. And thank you to everyone who supports the show regularly. I would be in a much worse mental state right now if I didn't have those of you supporting regularly through paper checks and PayPal and Patreon and the people that send in payments once in a while. We could use some. Oh, and we could also use some marketing because the show isn't growing because I don't know how to market things. But the best way to get people to listen to podcasts is for the people that love the podcast to tell other people about the podcast. And so please tell other people about the podcast as well, because I do think that there's not a lot of use in doing this show if only a small group of people hear it, you know? So yeah, if you could share this information, that would be great. Okay, so the next episode, I listened to a very fascinating hearing about the possible digitalization of the US dollar. And so I am going to make an episode out of that. And like I said, this is the second episode in September, and the government funding crisis is going to happen on October 1st. If there isn't something that either kicks the funding deadline or we magically get 12 funding bills to appear out of nowhere because most of them are not written and the Senate actually doesn't even have time to pass them all. So it's like we need to extend that deadline. That's what needs to happen by October 1st. If that doesn't happen, we're going to have a shutdown. And so there's going to have to be a bill that reopens the government or that kicks the deadline, or I don't know, but I'm paying attention. I think an episode might come out of that, but this is going to be one of those seasons that I don't know what the hell is going to happen. So I'm going to document things and I'll tell you about them after the fact. But until then, if you're a government worker, I suggest saving your money, because the consequence of a government shutdown is that people that work for the government don't get paid until it gets reopened. And a lot of people do essential services. Like, we can't fly on airplanes if the TSA agents don't come to work. So they have to work and just not get paid. The members of our military, they have to go to work. They just don't get paid. And so it's really unfair how many hundreds of thousands, in fact, probably millions of people are going to have to work for free for a while if this happens. So, yeah, save your money. I wouldn't plan any trips to any national parks or any kind of museums, definitely not to Washington, D.C. in the beginning of October, because everything that's not essential in the government, which museums and national parks, those are considered non-essential. All of those will be closed down. Yeah, here we go again. Here we go again. All right. Thanks so much for listening, and I'll talk to you soon. Bye.
We're surrounded now by liars coming at us through our TV screens.
We don't have a domestic spying program.
They're content to fight in black and white despite the many in-betweens. with the facts. And then he waves a flag to cover his tracks. As if a lie is alright, if the end will justify the means. Now we are so damn tired of being lied to.
The polar ice caps aren't going away.
We don't think we can deny it anymore. You can stick to your story if you think it flies. But we're not keeping quiet anymore. We are so damn tired of being lied to.
Government jobs consume the profits of the private sector.
We don't think we can deny it anymore. You can stick to your story if you think it flies. But we're not keeping quiet anymore. Now we're not keeping quiet.
These bills represent common sense, bipartisan solutions that actually solve problems.